All right, so I'm going to introduce our next moderator for our session. It's going to be Dr. Chloe Slocum, who is an instructor in physical medicine and rehabilitation at Harvard Medical School, Spaulding Rehabilitation Hospital here in Boston, and she is an alum of the Commonwealth Fund Fellowship, graduating as class of 2017. So, Dr. Slocum.
Thanks, Alden. And thank you, everybody, for being here and for joining us today. This will be our second panel, which will be focusing on advocacy and research. We have three incredible guests here today. We have Kerry Thompson, who is the program coordinator for the Disability Rights Fund, as well as the executive director of Silent Rhythms. We have Rachel Tanenhaus, who is the ADA coordinator and the executive director of the Commission for Persons with Disabilities for the city of Cambridge. And before that, spent 12 years as the program coordinator for the Health and Disability Partnership with the Massachusetts Department of Public Health. And last but certainly not least, we have Bill Henning, who's here with us as the executive director for the Boston Center for Independent Living, has been active in disability advocacy since 1984, according to his bio, and has worked closely with national groups such as ADAPT, as well as the National Centers for Independent Living. So I feel very honored that you all joined us today. And we'll be going through having them talk as panelists, and we'll be taking Q&A at the end. So without further ado, we'll start with Kerry.
Thank you. Is the microphone working?
Yes.
Yes, okay. Thank you. So thank you for having me here today. And I do have my notes because I'm from Louisiana, the land of storytelling and getting off the point. So I want to make sure that I stay on track. And thank you, Chloe, for that introduction. Maybe I should give you a little bit more background. So as I'm just told you, I'm from Louisiana. And as a little girl, I always wanted to be a pediatrician. And when I went to LSU, the pre-med advisor told me to switch major because she said that you will never get into medical school because of your deafness. So, life-affirming moment, and one of those things when you realize you want to go where the opportunities are. So I flipped a quarter, had New York City, tails Boston, to decide where I wanted to go, and Boston. I actually got my first job working for Brigham and Women's Hospital, so I stayed close to healthcare, and I worked in Brigham and Women's Hospital as a research specialist, and at the same time, I was also a volunteer for Children's Hospital. I was their on-call ASL volunteer, so if they had a deaf patient or a parent, or a deaf parent of a patient in the hospital, they would call me to come in, not to be the interpreter, but to be the friendly face that knows a language they know, because we know laughter is the best medicine as part of recovery and the experience. So imagine the experience of being in a hospital for weeks and weeks without somebody that you can talk to. So that's something important to consider when you're thinking about patients that have chronic illness that require inpatient stay. So let me say a little bit more about myself and why I'm here today. So as part of my time at Brigham and Women's Hospital, I also saw the need for better communication between the deaf community and the medical community. So I came up with a communication tool called Text for Deaf, and it was supposed to be a way to bridge the communication gap. And it was a way that doctors and medical providers could send a direct text message to their patients rather than trying to send a voicemail with, I hate and loathe with every fiber of my being. So that was something I was doing. And then I decided to go back to school and went to Harvard University to get my degree in human development. And from there, I took a little sidetrack in focusing on human rights because healthcare is a human right. And I wanted to think about not only about medical challenges for people with disabilities in the US, but think about people in developing countries. The world has 1 billion people with disabilities. 80% of those people live in developing countries. And so I'm here today to give you 3 different perspectives. One, as an international disability activist. The second, as a person who is deafblind. The third, as a woman with a disability. And I want to think about, is my slide up? Yes, it is. I don't have an actual presentation. I just have a very fancy little title slide. And that title slide, the title for my little talk is called The Left Behind in Health Equity. And clearly today, we're all here to talk about patients with disabilities, how we can improve healthcare for people with disability. But within that population of people with disability, there are several categories that I find are even more marginalized or even more left behind in the talk about how do we improve healthcare. So those 3 populations, the first one is the global disability population. The second one is the personal one for me, those who are deafblind and from the deaf community. The third one is women with disability. Thinking about those 3 categories when we're talking about health equity. And I'm going to start talking a little bit about the global disability community. Now, you may be thinking, why would I bring this up today? Because we're focusing on what the American with Disabilities Act has to say about healthcare and what the Civil Rights Act may say. But if we don't talk about how do we improve healthcare for people with disabilities in developing countries, who will? Who will talk about their needs too? Their needs is even more crucial and critical. And so, in terms of, there are 3 different types of international commitment relating to people with disabilities and healthcare. The first one, well, from a global perspective, the first one is the Universal Declaration on Human Rights. That's 70 years ago, and Article 25 of the Declaration on Human Rights declared that all people should have access to adequate health care. Then 10 years ago, the United Nations Convention on the Rights of Persons with Disabilities came into force, and it took the Universal Declaration on Human Rights to the next level and said people with disabilities should have the right to adequate health care. It's not given a special right, it's given the same right, but trying to clarify that we mean people with disabilities should have the same right as everyone else. Then the third international commitment is on the Sustainable Development Goal, which is the poverty reduction strategy to ensure that people with disability and people around the world, that we're trying to reduce poverty. And in order to reduce poverty, you also have to think about the disability population. So, as I mentioned before, 80% of the world's 1 billion people with disability live in developing countries. The majority of those people living in developing countries who have a disability will not see their 20th birthday. And it could be two different factors. One, it could be the nature of their disability. The second could be the barrier that their disability prevents them from enjoying their basic human rights. Some of this I memorized, some of it I did not. And going back to why am I bringing this up in this room? Because some of you may work with Doctors Without Borders, or maybe you're going to work for a physician on human rights. So if I bring this issue up now, perhaps you'll keep that in the back of your mind when you're working in international medical response. And a good number of the medical emergency response team that Brigham and Women's and other teams they send out to foreign countries to respond in times of conflict and natural disasters like hurricanes, earthquakes. We see it all the time for Haiti, Indonesia, and a number of other countries. So I want to make sure that when we're sending a medical team in the Boston area to developing countries to respond to these type of disasters, that we are also making sure to include people with disabilities in those countries, because people with disabilities are especially vulnerable in time of crisis. So what can you do? The first is to ensure that programs for emergency response include people with disabilities. It's important to work with local disabled person organizations. The third is to make sure you have a plan before disaster strikes. So I know I have 5 minutes left, and I'm going to quickly move into the second category that I consider to be the most marginalized within the disability population, and that is of the deafblind. And this is something very close to me as a person who is deafblind. You may be thinking, so I should explain my type of deafblindness. So I was born profoundly deaf and found out when I was 3, and at the age of 10, I was diagnosed as having retinitis pigmentosa. So the combination of the two means I have Usher syndrome. Right now, I can see a small hole this much. I use several forms of communication. I use Braille display, I use American Sign Language, I use tactile American Sign Language, and I use something called protactile. So I have many different options to communicate, and yet I still struggle to get access to healthcare because of communication issues. Now, most hospitals will definitely try to request an interpreter for me for my appointment, but there's a small pool of sign language interpreters. Then there's an even smaller pool of sign language interpreters who are qualified to interpret in a medical setting. That's a different kind of training. Then even in that pool, there's an even smaller number of medically qualified sign language interpreters who can work with the deafblind. So often I hear from the deafblind community that many of them struggle to get access to health care. They will put in a request for an interpreter, and they will follow up to find out if an interpreter was found. And often they're told, no, an interpreter was not found, or they may be told that there is an interpreter who was found but does not know how to work with the deafblind. So what do they do in those situations? Sometimes a hospital or medical community will say that the solution might be video remote interpreters, VRI. That is not a solution for the deafblind. How will I see somebody on the TV screen? So in some cases, the VRI might be a good source of a good solution, but for those who are deafblind or for those who are deaf, going to see the eye doctor where their pupils will be dilated, that is not a good suggestion. What can you do? I have so many more notes, and I don't think I'm going to get through all of them, but I'll just point out that it's important to work with deafblind organizations to try to come up with a solution ahead of time. I know we also struggle with the opioid crisis right now, and that's also impacting the deaf community and the deafblind community. And I want to make sure that when we're thinking about services to address the opioid crisis, we're also thinking about how to make those services deaf-friendly. And I'm going to wrap it up real quick. Hopefully I can talk to more of you later. But here is a quote that I'm going to say from Helen Keller. And her quote is, "Although the world is full of suffering, it is also full of the overcoming of it." So that's what I hope we can do today is I'm trying to share with you the suffering of the disability population around the world, and hopefully together we can overcome it. Thank you.
My turn? Okay. Hi. Oh, whoa. Hi. I guess the microphone's on. I'm Rachel, and as Chloe said, I have a background in both public health and in the ADA. The Americans with Disabilities Act, a lot of people think of as sort of the thing that the law that makes it so that we're supposed to have access and equal rights, including in medicine. I want to tell you as an ADA coordinator that the ADA is literally the floor. It is literally the least you can do. So when somebody says, "Oh, I'm all set," it's like what was said earlier about, things can be technically up to code and compliant, and people still can't use them. So I want to make it clear that my background is in the ADA, and we hopefully can be more broad than that. But also my background is in public health, as Chloe said, and that's sort of a weird line to straddle as a public health professional with a disability, because public health and disability they don't always get along, in part because people with disabilities are often still seen as an outcome, not a population. When I was in grad school, which was, oh God, I graduated 19 years ago in public health school, and it almost never happened that I would hear the word disability without the word prevention after it. And that wasn't what I wanted to study. I wanted to serve my community. And that's one of the reasons for some of these disparities, is that we're seen as a problem rather than an outcome, rather than a population. And consequently, there's a certain amount of distrust between people with disabilities and public health and people with disabilities in the medical community, because with all due respect, periodically, those fields turn around and try to kill us. To be blunt, eugenics was a public health measure at the time. It was a public health campaign, a very successful one in which the medical field participated enthusiastically. And in fact, the Nazis got a lot of their ideas from the United States. At the time, we were in the forefront of such things. So I try to be cognizant of that as somebody working, as somebody who deals a lot with the health of people with disabilities and with my own health as a person with a disability, that history is there and that culture is there. And yeah, look at this first 3 minutes and I already talked about Nazis. So y'all are like, this is going to be great. But yeah, that is something you need to be aware of, even if people aren't consciously thinking about that when they come into your office, that people are often used to being treated as a negative outcome and not as a whole person. And the other thing is that there is you do have to look at the big picture. You do have to look at the whole person. It's not that you want to see, I'm never into people saying, I see past your disability, because my disability is a part of me. It's part of who I am. This is the way the package comes, but there is more to me than solely my disability, and there's more to everybody than one aspect of their life. And so it's really important to look at big picture things and how they impact overall health and even the smaller details of people's lives. So in public health, and probably also in medicine, we talk about social determinants of health. And those are the big things that have an impact on the big systemic things that have an impact on the overall health of individuals. So we're talking about housing, we're talking about education, we're talking about poverty, we're talking about racism, things like that are large and very difficult for individuals to tackle, but that really have an overall impact on the kinds of disparities that people might face. And if you are in multiple groups that are at a disadvantage in those areas, like if you are a person of color with disabilities, then your outcomes are really considered to be, or your outcomes are generally lower, just because you are dealing with ableism and racism, that you are dealing with these lack of access to these larger things like education, like housing. And it's important to look at how that impacts people on a day-to-day basis. So I'm going to tell you a quick story. At my previous job, we carried out a statewide, the first ever statewide health needs assessment of people with disabilities, looking at the unmet health needs of people with disabilities. It was certainly not a perfect assessment, but it was the first one that had been done, and we got information that hadn't been gotten before, and we had a really good response. And so we came up with the top whatever things that people rated as a big problem for people with disabilities. And the top three, which will surprise nobody, were housing. Over 3/4 of people said that was a big problem. And access to mental health care and access to oral health care. And those were the top three, like with a bullet. And then like a while down, there were some more, but there were a lot of, those were the big three. And we had a site visit from our funders and the lady, who was a big deal in her federal agency, she was a very nice person, but she came in and she's looking, and they really wanted to fund stuff around treatment and management of chronic diseases and health promotion and health education, disease prevention, all of which is really, really important, and I'm not trying to slight it. But she came in and she said, what is going on here? Are they not getting our message? Do people not care about like quitting smoking and controlling diabetes and stuff like that? And I just kind of looked at her like she had lobsters coming out of her ears. And I said, look at this list again. 3/4 of the people are talking about how they don't necessarily have solid housing going on, or housing that they can function in. If I'm sleeping on my friend's couch for the 60th night in a row because I got nowhere else to go, if I don't know if there's going to be a roof over my kid's head tomorrow, I'm not quitting smoking that day. I'm going to take everything in the world, light it on fire, and put it in my mouth because, it is a hard day, right? If I have been up all night because I have an abscessed tooth because I can't get access to dental care, I can't get access to dental care, then I'm not going to the gym that day. I can barely function, right? So these are things that you have to look at and how they impact individual people. Now, we know that people with disabilities experience huge health disparities in every single indicator. There are very few indicators that there aren't really, really striking, 2 or 3 times more likely to, 10 times more likely to, et cetera. And one of the problems is that those are all underestimates because we're really lousy at collecting disability data. We're not good at asking questions that determine whether somebody actually has a disability, because do you have a disability does not get you the information you're actually looking for. And we don't ask all the people, and we don't ask the most marginalized people. So our health data come from telephone surveys, which are not going to reach folks who are deaf or hard of hearing. They're not reaching folks who are not in the community. So folks in nursing homes, folks in congregate living situations, folks who require a proxy, folks in prison, where we are warehousing Black and brown men with psychiatric disabilities who are particularly vulnerable to these various health issues. So we have underestimates for all of our data because we're not reaching the most vulnerable people, and we are not asking the questions properly. And our data collection systems are not. We're not collecting the data in a way that's accessible to people with disabilities. What I do on the municipal level, and I am new to this job. I've been there 3 months. So far, what I do on the municipal level is learn and be overwhelmed. But what we do on the municipal and small scale level, on both the macro and the micro level, actually really impacts what happens to the health of people with disabilities. So, for example, what you do around housing, like I said, the housing policies will impact the health of people with disabilities, will impact everybody's health. Access to outdoor spaces, what you do with the sidewalks and the roads, if people can get out of the house to even go to the doctor, what you do with your transportation, education, that sort of thing, that is impacting. We know that the more education someone has, the more likely they are to live longer. Right? We know these things. So our larger policy things that we do really impact the health of our population. Also, on a micro level, Cambridge, for example, has a facade improvement program where we will give businesses money to spruce up their fronts and look all nice, and we will give them more money if they will make those businesses accessible. So if you are a doctor's office, if you are a place where people can get healthy food, if you are any of those things, you have the opportunity. We as a city try to allow folks to have the opportunity to make their businesses accessible to people with disabilities so they can access what they need. Street maintenance is also something the city is very much involved in. And if you can't get down the street to go to what you need to do, then you're not going to access those programs and services. Transport, we have a relationship with the T and with other transport systems in the city, and I go to a lot of meetings about those things to talk about the needs of people with disabilities and make sure we're getting what we need so we can even get around to access programs and services. We have local public health. A lot of public health in this state is local because we don't have county health boards. We have 351 cities and towns. They all have their own little fiefdoms. And so like local public health really has an impact on what happens. Thank you. On what happens with folks with disabilities. And that includes stuff like our health education programs. Many of them are local, and our various health interventions. And sometimes the communication, one of the things I'm working on with the city of Cambridge is try to get accessible communication happening, because it hasn't been. And so we don't necessarily put out our social media or put out our health promotion materials and stuff in ways that people can actually access. So the thing is that I'm still finding opportunities to do this because I am new, but I want to let folks know that what you do in your office, when in your practice, makes a world of difference in what people are doing with their own health. If I show up in a doctor's office and all they want to talk about, this happened to me, I showed up in a doctor's office and all they wanted to talk about was that I was fat and blind. I got people who tell me that for free and they don't charge my insurance. So don't do that, because that will have the opposite impact. I never went for follow-up care with this person, and I am a fairly well-educated with regard to health, person, and if people are treating me like that, I don't show up again because I'm also human. So I think also being mindful of how you treat people and making sure that you are treating the whole person is really, really important. Thank you very much.
Hello, I'm Bill Henning, and I have the privilege, I think, of being the 9th speaker today. And I crafted a nice little talk that has now been said by the previous 8 speakers. And that's the truth. So I might be brief, which I don't think anyone ever really minds right before as we are moving towards lunch, but I'm not making it up. A lot of what I had hoped to say has been said. I've had a career as a disability rights activist over 30 years, and I am not a person with a disability, and to the degree I've had any success, I think underlying it has been an ability to listen to people. And obviously we're here to listen to folks with disabilities who have been able to share some very powerful experiences. Kerry, Rachel, Lisa, John Winsky before others. I didn't get here for the first couple of talks. But that should be really the watchword, I think, in medicine. I think as we look at trends in medicine today, it's, you hear these terms, patient-centered, which I almost hit the wall when I hear it because it's become like you say you do it, so therefore it happens. It's almost an empty term in a way, but there is no doubt nonetheless that medicine should be patient-centered and that we should listen to patients. And I think when you involve people with disabilities who have complicated systems, but who are, as everyone has said, just regular people, the listening really, really magnifies. Because nobody knows their bodies, their life, their health better than the individual with a disability. I do lots of advocacy, and I'm trying to assist a woman to get on the right health plan through all the changes in Massachusetts with Medicaid. And I'm writing an article, and I said, "What's your health condition?" And she said, "Which of the 17 do you want?" This woman has 17 interactive conditions, and I'm not sure just looking on an Epic EMR that you're going to get all of that. This woman knows what works, what doesn't. I know friends, John Winsky would tell you, as someone with a significant physical disability, how he is moved, how he is transferred is very specific to John Winsky. Zari, my friend in the audience, is nodding her head. You can get trained as a nursing assistant. You can work on a floor in a hospital, and there's a basic protocol. But for somebody with a significant spinal cord injury, it's really, really important to listen to the person and how you were moved. You can cause serious injury if someone is moved wrong. It's almost like after the football injuries we heard about earlier, immobilize the person. Well, none of that necessarily abates for a quadriplegic. So the listening is what's important. And through a process of listening, the Boston Center for Independent Living, listening to our members, and the hallmark of independent living centers is that we employ people with disabilities. 70% of our staff are people with disabilities. Majority of our board are people with disabilities, includes Ari, includes Lisa. We've learned the biggest challenge people face in medical situations is not being listened to. And I see Rachel nodding her head, and that's what people want. And I think that's what can best drive the practice and policies on a very micro level, on an individual level. We have had binding agreements, my organization, in conjunction with Greater Boston Legal Services, with Boston Medical Center, Brigham and Women's Hospital, and Mass General Hospital to improve compliance with the Americans with Disabilities Act, because there are lots of barriers. But I think somewhat at the root of them, and I'm picking on this or focusing on this because it's something I think to emphasize maybe a little bit different than what previous speakers said. But what we had to do is get people to sit down and listen. We were lucky to get in my world, a huge grant, $250,000 in conjunction with Boston Medical Center to institute a series of trainings for staff at Boston Medical Center. And what we all understood that the first set of trainings had to be about was listening. So we have a whole element of professionally done trainings featuring members of my organization, a person with an intellectual disability, someone with a speech limitation, and somebody with a significant physical disability for whom English was a second language. And they all just detailed scenarios of not being listened to on their conditions. I think John Winsky spoke of that quite well, of somebody asking, the old disability thing, what does she want? Well, ask the person. And that takes on extreme urgency, I think, in medical situations. From a real policy level for that at any kind of medical institution, I'm thinking of hospitals maybe because we're in the Longwood area, establishing focus groups, patient focus groups, even more than surveys, are really, really beneficial. We've worked with MGH on that. I had a meeting with Boston Medical Center on Monday where it was ostensibly a focus group because we had 6 of our members there talking about the policies and procedures, kind of an update on the agreement we have with Boston Medical Center. And you have, John was great, Rachel's great, Kerry's great. To have 6, 7, 8 people sharing that, it really moves the meter on understanding and opens the mind on what has to be heard. It's not rocket science, and it's not large either. You're never going to touch every issue. The woman with 17 disabilities, if you had 10 people, you might have almost 200 conditions. You can't know the answer for everyone, but you have to be open to the answer for everyone. Part of it's medicine, part of it's EMR, but part of it's what the patient has to say. I think the connection overall in serving people with disabilities in the medical settings really does tie in, especially to public policy. And the numbers Kerry mentioned internationally was staggering, depressing on the longevity for people. But my focus is the United States, Boston, Massachusetts, whatever. And we have to include, it's a cradle to grave element. The highest utilizers, I believe, of medical care are elders, and they're not going in because they're healthy. They're not going in often to a medical setting because they're ambulatory or cognitively able. And they deserve the same treatment as anybody else, and that's where we have to think of accommodations and changes. And a broader level as well, Rachel was talking about the social determinants of health. Any academic study that's going to look at race, poverty, and disability, you're going to have these Venn diagrams, and it's going to be a very big overlay in the middle where they all intersect. So if we're quite clear there's disparate care in minority communities, we've certainly established a case for disparate care in disability communities, and there's great elements of poverty, which leads to the need to have vigorous advocacy and policies that support the Medicaid program. My organization provides individual services to individuals along with a lot of advocacy. Mass health, Medicaid is the biggest area we do advocacy on these days because so much funnels through Medicaid in this state and nationally. And the proposed evisceration of Medicaid that was advanced in Congress last year, which was actually absolutely putrid, and I defy anyone here to try and defend it to me because it will be not a very quiet discussion, would have resulted in the deaths of thousands of people with disabilities. We may have never had a study to track that, to do some study of before and after, but we know by the people who walk through the door of my office what Medicaid is. It is the most important program, I believe, for people with disabilities in the country. Maybe special educations that helps integrate people into the mainstream is equally as important. We could have that debate and it would be a friendly debate, but from the health policy angle, Medicaid is it, and it funds long-term services and supports that enable people to live independently on their own. Rachel touched on, as I said, social determinants of health. Housing, it is the biggest issue people coming into the Boston Center for Independent Living have. The need for affordable, accessible, integrated housing. She detailed it perfectly. I mean, we find people in this city, which does not have an abundance of affordable stock, stuck in the third floor of all the three-deckers, second floor walk-ups. They need accessible housing. It may not be a fully accessible unit for somebody in a wheelchair. Maybe somebody with, what I call it, in my term, the poverty disabilities, people who grew up with lower educational opportunities, poor health care, lower employment opportunities. By the time they're 35, 45, they've got arthritis, back injury, diabetes, COPD, maybe some substance abuse, maybe some PTSD. They don't ambulate well. They don't have a lot of money. They can't find housing. They get isolated in units. They don't integrate in the community because it's hard to get in and out. All these factors, there is a link. So if you're thinking macro and social policy, to not think of it at the same time with the social determinants of health, I think it's very, very problematic. They play off of each other, even in transportation policy. Medicaid-funded transportation in this state uses private vendors. There's over 400. There's no real regulation of it. And we've had stories of drivers picking people up in inaccessible vehicles, drivers smoking. There were drivers taking kids with respiratory ailments to Children's Hospital smoking. We treat our poor people miserably. This is a whole fight, but it starts with listening on the micro level, and it's thinking broadly. It's a daunting challenge, but it's great everyone's here, and I appreciate the opportunity to speak. Thank you.
Thank you all. I have a few questions as a moderator. I know Dr. Iezzoni is also a commentator for this panel. Those were all amazing talks. I wanted to get to something that Kerry had mentioned as the third point of her presentation, which is this intersection of disability and gender and having been a person who has dealt with care and some of the care challenges as both a woman and a person with a disability.
Thank you. I'm so happy you brought that up because I didn't know how to squeeze that in 12 minutes. So going back to thinking about video remote interpreters, so imagine a woman who was deaf in labor, and the only option she has for communication access is a video remote interpreter. Now, I don't have children. I don't know how many people in this room have had children, but labor can be quite intensive from what I hear. So imagine a deaf woman in labor, and her only option is a video remote interpreter. So she has to position herself this way, but the doctor telling her to move this way, so you have to move the TV over here. And maybe you want to lean forward and lean back, and then you have the video remote interpreter saying, push. That's the type of push. So that's sort of an example of how women's health care in the terms of for a deaf woman didn't quite work out. There were also other issues that people think about people with disability as not being sexually active and don't provide sex education and talk about sexual health and human rights. So that tends to be a key issue for a lot of women with disabilities, is trying to access and understand about how birth control works and understanding how to talk about certain sexual assault, what to do in those cases. And I mentioned a little bit about the challenges of interpreters, and I didn't get to bring this up, so I'm going to try to quickly add it in here. Be very, very careful when, as a medical professional, to ask a family member or a friend to be an interpreter, because often the number women with disabilities, especially deaf women, are especially prone and vulnerable to sexual assault and domestic violence, and often that can be the culprit of those acts can be somebody from home. The very person who perpetrated an act could be that person that's in the same examination room, and you're asking that person to be the intermediary between the deaf patient and the doctor. So think about that. Make every effort to find another way to communicate. Use your instinct, and what Bill, you've said so much, listen. Not just listen, but also use your instinct. Thank you.
Thanks.
Could
Bill,
I just add a couple of things? Women's health is really a pivot point, I think, as you think of it, accessible diagnostic medical equipment. I think we're giving some stories today to hammer home the point, and I have a couple. Medical facilities have lacked scales, and if you can't weigh people, you can't judge people's wellness. And if you can't weigh people, you may give an incorrect dosage of medicine. And we had a member who that happened to at a local medical facility, and still happens periodically, as we know. And one time she goes in and says, "Where's the scale? I want to be weighed." The woman had had breast cancer, and she also has a spinal cord injury. And the response from nurse was, and this shows almost the acculturation of anti-woman things or whatever. "Oh, aren't you lucky? You don't have to be weighed today." Like it's a good thing. It's like the trivialization of wellness here because she was a woman and because she was a person with a disability. Another horrible story is one of our members went for an OBGYN exam, and like the person John Winsky said, his wife, this woman has spasms, and she went for an OBGYN and spasmed, and I guess trying to get her into the stirrups, so they brought a bunch of men in to hold her down. And she was pretty traumatized telling that story. She told it once, and it riveted everybody. She couldn't tell it again at any meeting. She wasn't afraid to, but it was too, she got through it once, but she allows me to say it. I'm not going to say who it was or anything like that, but it's these overlays: women and disabilities, racial minorities and disabilities, whatever, so it's something we all have to look at.
And I think that there's this idea that you're only allowed to fit in one box at once. I mean, first of all, you have to fit in a box. But second of all, because, I was listening to the not fitting into a dichotomy thing, and that the thing about, where if you don't, people are terrified of things that don't fit neatly into a dichotomy. But also, you're only supposed to have to deal with one of those at a time. And so, if you've got a woman with a disability who comes in for care, and, if she's a person of color, if she's lesbian or bisexual, if she is, if she's not monogamous, I mean, people have a hard enough time wrapping their brains around us having sex. If we're having sex with more than one person, mind blown. So, and then doctors tend to hit their limit. Nope, that's all the things I don't know how to deal with. I can in one page. Sorry, you got to come back a day when I got more brain cells working. So it doesn't work like that. So you have to be able to understand that people have complex and intersecting identities, and they are bringing their whole selves into your office. They are not going to leave part of it at the door for you. And if you expect them to do so, they're not going to come to you. They're not going to be they're going to lie to you, and they're not going to get the care that they need. And you're going to get frustrated because you'll be wasting your time.
Yeah, and the biggest issue we hear from people with significant mental illness and medical interactions is just the irresistible urge to ask somebody, like, is this imagining your ailments, your physical ailments, around the mental illness, just not taking at face value that I have an issue, my stomach is hurt for 2 weeks or whatever it may be. There are great elements of progress. I know there's very strong movement, I believe, for people with autism, for instance, in Mass General Hospital, but it's a bit-by-bit process.
Yeah, thank you guys. I wanted to ask specifically, since I know you're all been involved in disability advocacy and thinking, like Bill said, the micro listening and the macro thinking broadly. For instance, I've had patients that have not been weighed in 2 decades that come into me and just sort of assumed that they would never be weighed or that there wasn't a scale that existed. On the other hand, I've had primary care physicians who have sometimes, been dealing with someone who's maybe had a substance use issue or depression, where they sort of not addressed it because they're just sort of seeing the person with the disability, and they haven't followed up in terms of just basically what most of us in medicine would think of as a review of systems, and that I think can have not just a micro impact but a macro impact in some of these issues. Kerry talked about women in the deaf community, and actually having a population effect, if there's something that's flawed about the way that the system is actually addressing it through the behavior of individual providers. So what are some areas that you think are especially big in the macro space, in addition to housing and mental health, that you think that the broader medical community should be aware of? It's a big question.
Just the transportation is huge. You talk about accommodation. We talk with the hospitals about this, but I had the anecdotes of the private vendors, but appointments just get scheduled willy-nilly, and you may have somebody who has ambulation issues or whatever the issues are. Ambulation is easy to conceive of, but it can be anything. And facility X is here, and the campus a mile away, there's another. Just go over there. It may not happen. It may take an hour between. It may be that you get scheduled for an appointment at 8 in the morning, and your personal care attendants don't come in until 7:30, so you can't make it. Or you're taking a medication, that causes you to urinate excessively, and you need to have an attendant around. And the meds are in the afternoon, so all your appointments have to be in the morning. There are all these interactions. It's not, and these things fall to somebody sitting at a desk who's scheduling, utterly separate from the physician. There's that separation. This stuff's complicated, but the impact is broad. And one thought I had is a lot of people will take this. I'm an activist. We've sued the MBTA. We fight for better Medicaid policy, better housing. But when we have tried to get individuals into some of these campaigns, it's only folks like Kerry or Rachel. They haven't been involved in the specific BCIL campaigns, but it's only the leaders, the vanguard, who want to put out their personal health care story to other people, because we are conditioned to have a very strong, trusting relationship with our medical providers. And that's probably a very good thing. But if you're talking about highly medically involved people, they also feel very vulnerable, very vulnerable. The whole situations are vulnerable, right? You're there naked or half naked half the time, but your life depends on somebody. So you may not complain about things. One of the leaders, as we were approaching one of the institutions, this is a leader in the state on disability advocacy, and this person happened to have a spinal cord injury, and I said, so do you want to talk about the barriers you're facing? And they said, no, I've never had a barrier. I knew they had barriers because I looked at the person. I know they've had barriers, and I know the institution where they got their primary care, and I know we've had issues there. So about 6 months later, said, you had any barriers? I've never had any barriers. So I pushed the envelope. And 2 weeks later, I said, so you've never had any barriers? She goes, I have not. My husband lifts me onto the exam table every time I go to the doctor. And 2 weeks later, we had a 12 to 14-page affidavit detailing the litany of problems. It had been suffused, because you can't fight every battle as a person with a disability. We can't in life. You have to pick your battles, but there's so many. So this person is weighing, do I get this primary care around my spinal cord injury and the 6 attending concerns, or do I fight the indignity and the risks there? But I can't fight everything, and I don't want to do it. So I can go into a room this size with 100 people and go, who wants to speak out at an event on the against the MBTA? And everyone raises their hand, which may not be fair, because I would say the MBTA tries to do a good job, but back in the day they didn't for us, for sure. But if I go, who has health care issues, you will get, the number should be about 99.9% of the room, and we'll get maybe a 20% response, because it's personal and it's not, and it's dangerous for people to bring it out there too. It's risky.
Can I build on that a little bit?
You probably know it.
Well, I mean, but I think that one of the things that's important to recognize, and I think people are starting to recognize this with different kinds of oppression, is, like, I don't care that I have a disability, right? Like, sighted people are great, y'all are lovely, but I don't, like, sit up at night wishing I were you. And and it, it's all good, but but nothing is ever simple, and that is exhausting. And it's not because of my disability, it's because of systemic ableism. And the constant being nibbled to death by ducks, the constant sort of, that there's always something, that anytime I walk into a restaurant, I have to worry somebody's going to yell at me, no dogs. There's a dog under the table, for those of you who weren't aware. The constant having to, anytime I've ever been discharged from an emergency room, I've never been given instructions I could read. I don't go to nutritionists anymore because, between the fat thing and the fact that I can't read their 10 million charts, like that, they just don't deal. And I just, it's exhausting, and that will wear on you, and that will impact your health, and that will impact your mental health. And I think that there's a big difference between someone saying, and I have had a mental health care professional say this to me, because I do have a history of depression and anxiety, which are unrelated to my blindness. And I have had somebody say to me, yeah, of course you're depressed, you're blind, which is not the way to get me to stick around as a patient. And I think there's a difference between that and what my current therapist does, which is acknowledge the systems of oppression that I'm working in and how that impacts my mental health. And yeah, of course, we live in a world that was not made for us. And we are constantly reminded of that. And it's not, for some people, the disability is the problem, but in a lot of cases, it's not the disability that is the problem. It is the world and the way that people are treated as a result of it. And if you think that doesn't impact someone's physical and mental health, you're not paying attention. So I feel, and also the trauma, the fact that people with disabilities are more likely to experience trauma, particularly sexual violence. It is endemic in the disability community, and it's often from people we depend on for our lives. So I think that those are things that Folks need to, if you're caring for people with disabilities, and you are, whether they tell you or not, then you need to be doing trauma-informed care, which you should probably be doing anyway, because we're just so much more likely to have that going on both at the macro level and the micro level. Whew, that got everybody excited.
Thank you all. No. I want to ask Dr. Iezzoni if she would like to.
I was told that I had to do a commentary on this session too. So,
You want a microphone?
yes, I think that probably would be a good idea. Even though it means that my back is going to be to the room. This is a little awkward. But,
Why don't we get?
oh,
Do you
go
wanna
over
get
there? Okay. Sure. I will just one up Bill's story. That the woman who I knew who had to have men brought into the room to hold her while she had her exam, the men that were brought into the room were the security guards with guns on their hips. Yeah, that made her not want to go back to that healthcare facility again. So I know that we are at the end of the session and we're about to have lunch. And so I actually am going to ask forgiveness from my wonderful advocacy colleagues on the table and ask permission to medicalize for a second. Okay, because I know who's
It's
in
you,
this
so
the
it's
thumbs
okay.
up from me.
You're okay with that? Okay. Because I think it does have to be said a couple of medical things. First of all, people with disabilities are routinely excluded up front from randomized controlled trials. Therefore, we want to practice evidence-based medicine. We can't practice evidence-based medicine about people with disabilities because there's no evidence about people with disabilities. And so, therefore, people with disabilities aren't going to be informed the same way that other people are about their health care. I think that most doctors are notoriously poor about assessing functional status. And Chloe, you're an exception. PM&R doctors are exceptions, and maybe neurologists and some others, but the vast majorities of doctors who care for you in this room are not very good at functional assessments. And frankly, they don't necessarily always view that as part of their job. I have been told by primary care doctors that it's part of nursing's job to be able to do the functional assessment. Bill actually mentioned EPIC. That's the wonderful electronic medical record that places like the MGH and the Brigham has. The Beth Israel has its own homegrown version. I don't know how that works. But EPIC, for example, it may be true at Spaulding. But the routine EPIC medical record does not have a specific place to record functional status. And so if you don't have a routine place to record functional status, guess what? You're not going to record functional status. And finally, Rachel talked about collecting data. I mentioned during my comments earlier that Section 4203 of the Affordable Care Act required standardization for making medical diagnostic equipment accessible. Well, there was another section, Section 4302, if you transpose the 3 and the 2. It was just funny that the numbers worked out that way. Section 4302 required the Office of Minority Health to come up with standardized questions for federal surveys about disability. And so they did that. There are 6 questions, and 6 is certainly better than 1, which historically has been used in most surveys like the Behavioral Risk Factor Surveillance System. And so those data are beginning to be collected, but we still have very, very little data upon which to assess population health for people with disabilities. So those are my comments.
Excellent. Thank you, Dr. Iezzoni.
Thanks.
All right. Does anybody else have any questions? Yeah.
Hi, I work in child welfare in California, and I recently did a study which in a roundabout way led me to look at the situation for children with disabilities in the child welfare system. And it really hit home that these are some of the most vulnerable people probably in the world, and they face adversity off the charts. I was wondering if you have any policy recommendations for the state of California to improve the care of kids who really don't have people dedicated to advocate for them.
This is our panel. I know one of our previous questions was about children with disabilities in Massachusetts who are transitioning to adult care, and how pediatric care and adult care are coordinated, and how those two systems of adult and pediatric care can sometimes cross in the night. And certainly, I think there's vast improvement that could be achieved in both systems. I don't know if Rachel, you want to speak to that, but certainly I'm happy to connect with you offline, and our colleague with the other question. I think to our panelists' points, it's hard to improve something and show that you've improved it when you're not collecting data, and I think that a barrier is this listening at the micro level. But it's also a barrier for policymakers, because listening at a macro level involves collecting some of this data and involves actually describing things so that resources can be directed to some of these most vulnerable populations appropriately, and to make sure that we understand the problems that we're trying to solve, rather than trying to solve problems that we think are there. But as Rachel mentioned, someone may come in and say, what's this? The problems that we thought were really big are not the biggest problems for this population. So I don't know if
I wanted to say that, first of all, thank you for your question and your work.
Yeah.
These systems are not great at trusting people with disabilities and believing us when we say things, and empowering us with opportunities to communicate. And so I think I'm a firm believer in the tenet of nothing about us without us. So I'd like to know, in the creation of your policies, and are you consulting with people with disabilities? Mm-hmm. Particularly, obviously you meet one person with a particular disability, you've met one person with that disability. But are you involving people with the disabilities that you're seeing among these kids? And are you giving these kids every possible opportunity to communicate their needs? If they don't communicate like everybody else, how do they? And even if they are nonverbal, they communicate. Mm-hmm. And what are you doing to ensure that that they have the opportunities to meet and spend time with people who are like them? And I think that is huge. Parents with disabilities are far more likely to have their children taken from them and put into the system. And so even if you are, even if you're an adult with a disability, the system doesn't really take you very seriously or presume competence. So I think those are foundational things that need to be addressed in the system in order to do right by your kids in the system who have disabilities, is that you have to start from the presumption that they, all the kids in that system are incredibly vulnerable. You have to start from the presumption that those kids need to be given all the opportunities everybody else is, and they're not going to look the same.
Mm-hmm. Kerry? Yeah.
I'm not sure if this word is emphasized enough, but empowering, and it was something I was thinking about for the previous question. Maybe, I don't know if many of you have heard of this term called IEP. It's in the education system, in which they have students with disabilities meet with their teachers and parents and all the different education providers. And I think it's something good to have a similar model in terms of the medical community, having children with disabilities have a chance to sit down with their doctor, their parent, and talk about their questions. And even adults with disabilities don't feel empowered to come in and say, these are my questions. So as a little girl, my mother told me, today we're going to the doctor. What questions do you have for the doctor? Think about all the questions you want to ask the doctor. We go to the doctor. My mother said, Kerry, do you have questions for the doctor? So it's a little thing that parents of a child with a disability can think about, or any caretaker of a child with a disability. Give them the opportunity to lead the question, to lead the conversation, to ask what the questions are. Even doctors, maybe the parent is not doing that. You want the doctor should try to say, I have a chance right now in this room to ask this child, what question do you have? You're giving respect to that child with disability to say, my opinion matters. So.
I will say to the question, and it's really a troubling question because it doesn't, I think what Kerry said is absolute, and Rachel is on the mark.
Yeah.
But, you know, as someone in disability rights all these years, there is this separation in a lot of what we do. Disability rights, in a lot of ways, becomes the purview of adults. Adults with disabilities. You could ask Maura, who's deep with the ARC, but that's very parent-driven. You're talking about situations where the parents are absent, and it's a troubling question that is a little bit haunting. Which doesn't help you, but maybe affirmation from us.
Okay. You have another question?
Yeah. My name is Han Ho. I'm from McLean Hospital. I practice addiction medicine, pediatric and geriatric psychiatry. So I'm glad that the panel discussed issues like mental health and addictions, opiate epidemic. I would also like to include one thing, which is in addition to supporting people with disabilities, I think that we also want to support their family members and also caregivers, because we know that, for example, issues like caregiver burnout and stress is something real, and but unfortunately sometimes we overlook. So I was wondering whether any one of you would say a few words about supporting and also advocating for family members and caregivers for people with disabilities.
I think we have a caregiver support problem in this country, and it's not specific to to folks who provide care for folks with disabilities. I think that's also important, but I think that we're not great at self-care in this country, especially if we are if we're tasked with taking care of other people, especially if we are women, especially if we are people of color. Like, we're not, I mean, we don't have the supports for it. It's not a character flaw that we're not great at it. I mean, but I feel like there is a way to support caregivers without, and I'm not saying that you did this, but that it's a fine line that you have to sort of ride in the disability community with where you make sure you acknowledge the needs of a caregiver without putting the role of being a burden on the person with a disability, which again I realize is not what you said, but I want to make it clear that that is culturally a thing, right? And that in the disability community, that we are often that you want to provide that care, or you want to provide that support for the caregivers in a way that doesn't minimize the agency and the dignity of the person with a disability. And I think everybody's happier that way. Everybody gets what they need, because we also have a problem, frankly, in this country of, and again, I'm not talking about the people that you see necessarily, but we also have a problem occasionally of caregivers injuring or killing their people with disabilities, and then the press goes, "Oh, they were under all this pressure." So and if anytime you see a story like that, like the press is always like, "Well, the demands of," and I think that there is a way to lift up and support caregivers and make sure that you are acknowledging the importance and the needs of the people with disabilities at the same time. And I just want to say that that is really important to do, that you are looking at the whole family. If you're looking at somebody's caregivers, you're looking at the whole family. Nobody in that family exists in a vacuum. And you want to be sure that everybody works together on this and that everybody is treated as though they have agency, because they do.
Yeah, I know in the mental health community, since you're coming from McLean's, I know NAMI and the state National Alliance for the Mentally Ill is when I joined this movement, a lot of people with mental illness would look askance at NAMI because it was so family-centered. Yeah. And I would mention NAMI like, "Ooh, do you ever talk to them?" And then people like want to hit me. But I know that under in the last decade, they've made a real effort to expand to a view that would respect what Rachel just said of looking at the consumer, while also trying to share to individuals the fundamental importance to so many people of their family as a support system in a difficult situation. And it is not an either or, but it does cross these cultural lines, that are a term Rachel used, and I think that's very accurate.
Okay. I know we had a couple more questions. Yeah.
Hi, I'm Anthony Chen from Tacoma, Washington, and I'm going to ask the panel, see if they would answer the micro-macro question differently if I reframe it. As I was listening to the question, and the answers occurred to me that it was very culture-bound, in the sense that we're sitting in a healthcare setting. Boston is, yeah, it struck me, now I'm back in Boston. It is so specialty-oriented. Mm-hmm. And also, your answers were all about health care and not about what we've talked about earlier, that it's really about wellness, functional status, and the bigger definition of health, right? So I'm just wondering that if we reframe the question for the micro-macro to say, well, it's that same shift, like you talk about adverse childhood experiences for individuals, but you need to talk about community trauma for the community, right? Yeah. So for your communities who are disabled, what are the macro issues that you would shift the whole community issues, not healthcare issues, but issues that would support their wellness in the 95% of their life which is outside of the medical centers?
Yeah. So I'm going to let our panel see it, but I think we've heard some good things around housing and transportation. Housing is huge.
Housing is the biggest social determinant for the people with disabilities we see. I was at a conference roughly a year ago put on by the Blue Cross Blue Shield Foundation of Massachusetts on social determinants of health, and they looked at industrialized European countries versus the United States, and they have a much higher spend on social services and less on healthcare. We have the scale on our country, of course, is high on healthcare, less on social services. You know, you can look at all the reasons for high medical costs, but they were making an argument, certainly part of it is what you spend on social services. So if you accept that some people are going to be down on their luck and need supports, I think we probably come from that view here. The whole housing issue, I see desperate people in my office every single day. They're coming, and they're bouncing around agencies too. You know, we run a housing workshop every 2 weeks, how to access subsidized housing. And, my staff can be quite happy. We got so-and-so housing, and I know it's just robbing Peter to pay Paul. That means that somebody else is not getting housing on a list, which is pretty depressing.
Yeah, we send you a bunch of those people because they call us and they're like, so I'm not going to have a place to live in 2 weeks. And we're just like, yeah. Yeah,
and they'll often have kids. The kids may even get pulled into the Massachusetts social service system. But, there's elements of progress. There is this overlay, the monster in Washington. I'm not going to call it anything any different. We have a Secretary of HUD who wants to reduce support for subsidized housing. That does not equate with the life experience of, 30 people coming through the doors of my office every week and calling our information referral all day long. Where can we find subsidized housing? It's a white-hot market in urban areas of America where poor people, racial minorities, and disabled people congregate. Access to services, lots of historical reasons.
And I also think it's important when we're looking at stuff like wellness, what do we mean and who do we mean it about? Because so now it used to be that wellness was, are you sick or not? And now wellness is something bigger. And I was at a presentation and this guy came and presented, I wonder if he's in the room. Anyway, this guy came and presented and he was presenting on this new model of wellness that had 8 realms or 12 realms or some number of realms. And it was like, and it was wellness around housing and employment and things like that. And I and I'm sitting here going, look at you, able-bodied white dude. Because, like, I raised my hand and I was like, yeah, sorry, no, it wasn't you.
Okay. And your dog is
He's sitting
trained
next
too,
to
so
you.
I'm not worried.
Yeah, I can't even get her to eat her. I can't even get her to eat her food. Don't worry, you're safe. Yeah, but I mean, he's up there, and I said, what about people with disabilities who don't have access to that? Like, we can never be well under your definition. There's no such thing as wellness for people with disabilities because our unemployment is endemic and our lack of access to stable, accessible, affordable housing is just a fact of life. And like all of these categories, I'm like, it is important for your wellness. I'm not saying it's not, but you've got whole populations of people. And, and if you're a person of color with a disability, if you're, any number of these groups of people that don't have access to these things in any kind of equitable way. And so you can look at these categories, but they don't take into account the systems behind it that talk about access to these things. So are you saying that these whole populations of people can't be well? And I was not his favorite person. But like, you have to, when you're coming up with these paradigms and when you're looking at the big picture, you also have to look at who's not in that, who wasn't, who may not have been at the table when that thing was drawn up, or who can never achieve that thing you just talked about when it's set up as something achievable.
Thank you. I know we have one more question that's been waiting for a little while.
Thank you. Hi, thank you so much to the panels today. I'm Mara Sullivan. I'm the Director of Government Affairs at the ARC of Massachusetts, but I also run a medical student training program in enhancing care for people with autism and intellectual and developmental disabilities across Massachusetts, and we reach about 600 medical students a year. And I just wanted to encourage a little more discussion about autism and intellectual and developmental disabilities, and maybe even some representation for your next conference. John had mentioned, the challenges of getting here, and I'll tell you it's challenging for people with profound autism or IDD, but it would be great to hear from them. One of the great pieces of our program at the ARC is that the medical students get experiential learning. So they spend time with families and with individuals, and they really come out of the program with understanding the strength of people with disabilities and the resilience of the families, but mostly they come out with a willingness to treat our patients, and not just a willingness, an interest, and a confidence that they didn't have before. So just playing on that piece about listening, it's experiencing, it's knowing, and we're hoping to keep growing our program. So just on the hopeful note. Thank you.
Thank you. Thank you very much for your comment and for your work. Thanks. Okay. I think Alden's saying no.
That sounded like Alden. What? Come on, one more.
We're between people and lunch.
Octavio, you bullied us yesterday with your questions, so I'm going to push back today. I want to say thank you to our panelists and thank you to Chloe for moderating.